Good evening. Welcome to Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist. I focus on heart attack and stroke prevention. I own Apollo Cardiology with my great team here in St. Louis, and our job is to find people's root cause reasons why they're developing vascular disease, or what are the risk factors that they would in the future, because they don't want to end up like grandpa, dad, or uncles that have had cardiac events. Not saying that women can't, but vascular disease tends to be a man's game early on in life, unless you have lipoprotein(a). So I've been doing these Instagram lives since 2019 to help you figure out that it's not only about cholesterol that drives your vascular risk, it's about the endothelial lining, the glycocalyx, and also often talking about biohacking topics such as blue blocking glasses to help optimize your circadian rhythms. So if you're interested in that, every Monday morning, I put in my stories a box where you can submit your questions and we answer them live here, take them in the order received. And if there's time, usually is, if you get your question in the comments while we're chatting, I'll answer that as well. If you're looking for any more details about the things that I teach about, my school community, drtwyman.com/school has more information. We're going to start doing some case studies there so people can share their labs, their imaging, whatever else they want me to review. And I can give you my take on what is really going on with your vascular health and what potential things you can do from a lifestyle standpoint, medications or supplements. So with the housekeeping out of the way, we'll jump right in. So the first question up tonight is about acetylsalicylic acid, which is aspirin. Is it thin the blood out? It inhibits platelets. It's not an anticoagulant, so it's not a true blood thinner. And why and how does the blood get thicker? Well, there's many reasons. From a quantum reason, it's a lack of structured water in the blood. The blood becomes more viscous when you lose net negative charge. But if your blood is stickier or thicker and it's viscous, that causes more shear stress to the glycocalyx. And you have less nitric oxide availability at times because of that. So things that can improve the flow rate is optimizing infrared light into your system. This is why sun exposure is critically important for vascular health. But if you're not able to get sun exposure, then exercise, increasing the heat while you're exercising, provides infrared light to your system. Sauna therapy, that's one of the main benefits from sauna. Yes, you sweat with it. Yes, it stimulates increased heart rate, much like cardio exercise would. Yes, you get rid of heavy metals and plastics and improve brain-derived neurotrophic factor. But one of the main benefits is that infrared light is absorbed into the water in your system and it structures the water. So that is why you want to optimize infrared light, because it makes the blood flow more effectively. Next question, when getting the purple lines on the legs, does it mean that tiny capillaries are getting blocked? Not generally. This is something where it's most likely spider veins. Generally it's cosmetic. Oftentimes, prolonged standing is one of the causes for them. If they are not painful, there's likely nothing to do for them. You can wear compression stockings sometimes to decrease the swelling if it's causing any swelling or discomfort, but having varicose veins or spider veins is not a precursor to developing coronary atherosclerosis. Question, what is the big difference between a statin and a lipid cholesterol medication? So it is one. So again, I talked about that cholesterol is part of the equation for developing plaque in the arteries. It is not the only thing, and it's not the most important thing. Your stress in your life has almost the same effect of damaging arteries as having high blood pressure. Lipids are part of the plaque. They're not the primary cause in the majority of people. So if the person is not able to keep their arteries pliable, optimize nitric oxide, low inflammation, and they have serial scans showing they're developing more plaque in the arteries, they should consider being more aggressive, lowering their lipoproteins. And using what tool to do that can include statins, bempedoic acid, which is Nexletol, PCSK9 inhibitors, and ezetimibe. Those are the 4 classes of medications that have MACE outcome, major adverse cardiovascular endpoint outcome, meaning they lower heart attacks, strokes, need for revascularization. So statins are just one of the cholesterol-lowering medications. And then the next question tonight is about Dr. Nick Norwood has a saying that ApoC3 is more indicative of heart disease than ApoB. Is this true? Yes, in part. ApoC3 is found on the outside of lipoproteins that also do include ApoB. They're going to be triglyceride-enriched particles, and that may have an effect on how the body breaks down certain fats and utilizes those fats. So if you have high ApoC3, it affects lipoprotein lipase. So typically, people who have high ApoC3 are generally metabolically unwell. So you can, if you don't have access to ApoC3, which you can check, with Cleveland Heart Labs, Quest, maybe with LabCorp may do it as well. You can look at, markers of insulin sensitivity. So, what is the HOMO-IR? What are just your triglycerides? What are your VLDLs? If you have abnormal values there, you likely have abnormal ApoC3. But it is an association that people who have genetic mutations in ApoC3 and have naturally low levels do have a prolonged longevity benefit often. All right. So those are the pre-submitted questions. We'll jump into the comments. I saw a couple popping in here. Question, thoughts about Mounjaro for someone who has continuous slightly high glucose, A1C55, and is trying? Okay, so Mounjaro, one of the GLP antagonists, or I should say agonists, can be useful in that instance. I mean, the main use case is for treating diabetes. So if your A1C is above 6.4 and you're diabetic, definite indication. If you have a BMI over 30, definitely indication. But the people who don't fit the standard, kind of molds, it can be beneficial, particularly if the person has a lot of food noise, they have a lot of inflammation, they have endothelial dysfunction, it may be useful. But my one caveat, without knowing more about the person, is that, oftentimes when you start these medications, you got to be willing to take them for the long haul. These aren't medications you generally start for a few weeks, months, and come off. It's usually a lifetime decision because the benefits usually accrue the longer the person's on them. This is mostly for the patients who are using it from cardiovascular benefits. The trials showed that with Ozempic, patients that were on the medication had 20% less major adverse cardiovascular endpoints, but the risk factors were present. Once, I should say, the risk increased back 20% if the person stopped the Ozempic medication. That also being said is that it's not a free pass to avoid doing the lifestyle things that people need to do. So focus on your strength training sessions, ideally at least 2 times a week. If you're trying to gain muscle, it's 3 to 4 times a week, and optimizing your dietary protein. Generally want to go for about 1 gram of protein for the pound of ideal body weight that you're trying to obtain. And I think this is a continuation question for the person who has 5 pounds of visceral fat. Yes, it's likely to help improve visceral fat, particularly if it's epicardial around the heart. There's another medication that I often use in patients who have high visceral fat burdens called pioglitazone. It's an older diabetic medication. Using it at low dose may be beneficial. The reason it kind of fell out of favor is that it does not promote weight loss. It may actually cause some weight gain, mainly fluid. So a lot of people didn't want to use it if they were trying to lose weight. But if people use that in addition to a GLP, they may have more significant reductions in visceral fat. All right, so switching up to heart rhythms. So it says that they're getting multiple premature ventricular contractions during vigorous exercise. Is that something to worry about? Potentially. Is the person, symptomatic with the PVCs? Are they getting chest pain, severe shortness of breath? Do they feel like they're going to pass out? Can the PVCs be basically suppressed with increased activity, or do they get worse and worse as heart rate increases? So would do more, evaluation to figure out what's potentially driving them. Ischemia would be the most concerning reason. Lack of blood flow to the myocardium could worsen PVCs if the heart rate is increasing and the PVCs keep increasing. It can be due to electrolyte imbalances, low potassium, low magnesium. It can be due to thyroid dysfunction. So there's not one answer to why people have multiple PVCs, but if the person's very symptomatic, they deserve a bigger workup. Next question is about a Cleerly analysis. So Cleerly is one of the AI companies that does an AI overread of CT coronary angiogram images. So the person reports that their total plaque volume was 10.8 and was 7.8 3 years ago. So that would be a very small increase in total plaque volume in that period of time. They're not really talking about the staging scores that they used to have. It used to be that if you had a Cleerly score up to 250 millimeters of plaque cubed, it was considered stage 1, 250 to 750 was stage 2, and above 750 was stage 3. So this is clearly in the stage 1, which was kind of the intermediate risk category. If there's not been a generally, if you're, the Cleerly is a little bit different than the calcium score test, and what is considered normal plaque progression. I'm not quite sure there's an actual linear trend for the Cleerly analysis for most people, but I know the data off the top of my head is that the CT coronary calcium plaque, if you're not making some type of intervention in your medications, supplements, oftentimes the calcium score test will increase about 20% a year. So the Cleerly is a good test at looking at plaque volume. It is very sensitive, but it would be more interesting that did you do anything different in the interim to make sure that the score didn't significantly increase. And ezetimibe can lower lipoproteins, but again, it's more about how optimal the nitric oxide pathways are. Does the arteries have good nitric oxide from lack of high homocysteine or high uric acid? Are there low oxidative stress and inflammatory markers in the blood? And stenosis on those type of scans would be very uncommon with that total plaque volume. So stenosis, generally is more concerning for symptoms. So most Cleerlys, you're not going to see stenosis greater than 70% because that's the wrong test if somebody's highly symptomatic. All right, and then somebody else has, I think it's a follow-up to the one about the PVCs. So they said that they're having mild chest pain, worse when heart rate increases. So this is definitely something I can't answer on Instagram without more history. Those type of symptoms require workup with your local doctor. Do not take that lightly. Chest discomfort needs to be worked up. Figure out, is it due to ischemia? So talk to your local doctors. And you're very welcome. Yeah, my job is to try to explain these things. I try to use analogies when possible. And this is my full-time job, is working with patients to figure out, how to help them understand what is truly driving their vascular risk. Cholesterol, I will always talk about it. It is important, but I think sometimes on social media it gets too hyper-focused that it's all about ApoB or LDL cholesterol. You have to address it, but it's about managing your stress levels. It's about your sleep optimization and your circadian rhythms. It's the timing of your meals. It's the quality of your exercise. It's your inflammation. It's your endothelial glycocalyx underlying endothelium. It's more than just one number on a lab report. So vascular disease, unfortunately, is still the #1 killer of men and women worldwide. Shouldn't be, but it is. Approximately every 40 seconds in the United States, somebody's having a heart attack. And most people did not know that they're at high risk of having a heart attack before that happens. So that's my mission, is to help people test, don't guess, find out, are you at higher risk? Do the right testing. If you want to work with us, outstanding. We work with patients from all over the United States. We'll get you the right testing. But if not, talk to your local doctors. Consider CT coronary calcium score test if you're over 40. If you have the ability and interest and want to know exactly what's going on in your arteries, the CT angiograms tell you the quality of plaque in the arteries. If you have access to carotid scans, you can find out what is your vascular age and do you have vascular inflammation. So if you look, you often will find plaque sooner than the person has symptoms. That's the goal. If you find somebody who's higher risk, start treating those risk factors more aggressively. So appreciate your guys' time and attention. Every Monday, 6 p.m., we'll do this Q&A. Monday morning, the Q&A box will be in my story, so you can submit the questions and first come, first serve. And then if you're looking for more in-depth answers or more in-depth education, my school community, drtwyman.com/school is the best place to actually look at. So hope you guys have a great rest of the night, and we'll see you next time.